Good evening, everyone. My topic for today is geographic atrophy in age-related macular degeneration. My moderator is Dr. DAD ma'am, Dhanashree Ratra ma'am. So what is geographic atrophy? It is defined as sharply delineated round or oval area of hypopigmentation or depigmentation resulting from loss of photoreceptors, retinal pigment epithelium, and choriocapillaries. It is usually referred as late or advanced form of non-neovascular AMD. In this, we can see the increased visibility of choroidal vessels. According to many studies, the minimum diameter of atrophic patch has been estimated as more than 175 micrometers. Now, according to AREDS classification, it is classified as intermediate or late form of AMD, depending upon the involvement of foveal center. And according to the latest classification of Bachmann's Initiative of Macular Research, it is classified in late form of AMD, irrespective of the involvement of foveal center. Moving on to epidemiology, the global prevalence of AMD is 8.7%, and the global prevalence of geographic atrophy is 0.66%. Usually it is found in age group more than 60 years of age, but it is more found in age group over 85 years of old, that is 4.4%. In mild or intermediate form of AMD, the risk of progression to geographic atrophy is 1.3%. Now, there are various risk factors which are similar to the risk factors seen in AMD, that is aging, family history, smoking, cholesterol levels. High level of HDL has been termed as a protective factor in AMD. Then genetics, light iris color, found more in whites and females, and even dietary factors deficient in antioxidants, they are more prone for geographic atrophy. Development of geographic atrophy, the factors responsible for the development. The most important factor is the large drusen which has undergone regression. Usually RP degeneration is noted anterior to the drusen, and when this alteration progresses, it leads to hyperpigmentation, ultimately leading to regression of the drusens, followed by hypopigmentation and eventually geographic atrophy. Usually this RP alteration begins in perifoveal area, but sooner or later it will involve foveal center. Features present at the site that eventually lead to geographic atrophy. Drusens more than 125 micrometers, if they are present, 96% chances are there for geographic atrophy. Similarly, confluent drusens in 94%, drusen size more than 250 microns in 83%, refractile deposits are present then in 23% chances, and hypo and hyperpigmentation areas. The geographic atrophy may form independent of the drusen, which can result in horseshoe shape or ring-like configuration, initially sparing fovea. Now, this diagram actually shows the geographic atrophy independent of the drusen, and as the time progresses, this geographic atrophy sparing the foveal center, it is spread in a horseshoe shape or ring manner. The geographic atrophy can also form after collapse of drusenoid pigment epithelial detachment. There multifactorial causes can be there: poorly regenerating RP, oxidative stress, environmental stress, decreased choroidal blood flow. They results in appearance of drusens and lipofusion deposits, and these deposits, they trigger inflammation via multiple pathways. The most important pathway is complement cascade, and in that also alternative pathway is the most important pathway, as well as NLRP3 inflammasomes, which is involved in RP destruction. Now, genome-wide association studies have identified 19 SNPs, out of which 4 are directly contained within complement cascade. That is complement factor H, complement factor 1, C3, C2, oblique C5, complement factor B. The strongest association has been found with CFH genotype, and the homozygous carriers of Y402H variant of CFH genotype, that they carry 2 to 4 times more risk for developing geographic atrophy. Histological alterations. Now, this is the diagram, this is the representation of a young age group retina histological changes. In this, RP is seen as a single layer, and their choriocapillaries and Bruch's membrane can be broadly classified into 3 layers: inner collagenous zone, elastic layer and outer collagenous layer. But in age, as the age progresses, the RP basement membrane we can see basal laminar deposits and apart from that, coated membrane bound bodies and collagens can be seen in the inner layers of the Brooks membrane. Now, earlier AMD changes, when the AMD has just started, the RP now no longer remains a single layer, and there's a basal laminar deposits started accumulating. Early patchy form of basal laminar deposits occur. Then these membranous debris, they might be found at the apex, or they might be found in the Brooks membrane layer. But in more advanced form of DMD, now this is a late form of basal laminar deposits, which are more amorphous in nature. And as well as that, we can see that there are stunted cone segments and shrunken choriocapillaries. So these are the histological alterations found in as in advanced AMD. Photoreceptors changes, usually rods are damaged more as compared to cones, and there is a reduction in the number of nuclei in outer nuclear layer. Short and bullous inner segments are found. In choroid and Brooks membrane, there is a loss of choriocapillaries, Brooks membrane thinning, and large choroidal arteries get visible. Usually the patient comes with the symptoms of blurring of vision. Geographic atrophy is most of the time bilaterally involved, though it may be asymmetrical involvement. More difficulty in doing near activities, and patient also might complain of impaired vision in dim light and reduced contrast. Now there are many differential diagnoses like Stargardt's dystrophy, pattern dystrophy, Viteliform macular dystrophy, especially adult Viteliform macular dystrophy. RP RIPS, it is just a differential diagnosis when seen because one area appears to be RP atrophied. But if we go on seeing the fluorescent angiogram and OCT, we can very well differentiate. Then there is a central areolar choroidal dystrophy and chloroquine hydroxychloroquine toxicity. Now, this is a Stargardt's. Usually, Stargardt's dystrophy usually seen onset can be in early childhood also, but it can be in adulthood also. Pisiform flex, then silent choroid on fluorescent angiography, they can be differentiated from the geographic atrophy. And hydroxychloroquine toxicity, bullseye maculopathy type of lesions can be seen, but the patient will give the history of the usage of the drug. Then pattern dystrophy, it can be reticular or butterfly shaped, which can be differentiated from geographic atrophy. Then central areolar choroidal dystrophy, this also might be seen in adulthood also, but on autofluorescence, there is a speckled autofluorescence. Drusen's are not there in CACD, and this speckled autofluorescence is well confined to the region of the atrophy, unlike geographic atrophy in which the autofluorescence might be away from the lesion also. Now there are various imaging modalities which can be used to diagnose this geographic atrophy. The first and foremost, most importantly used is color fundus photograph, in which it appears as a sharply demarcated area of RP hypopigmentation with increased visibility of underlying choroidal vessels. Now in fluorescent angiography, these lesions are defined as areas of hyperfluorescence, window defect, but as in the later phases of angiogram, this intensity starts fading up and the size remains the same. Indocyanine green angiography, in early stages, they appears as well-defined areas with increased visibility of larger choroidal vessels. And there is a loss of uniform gray appearance of choriocapillaries in early stages. Fundus autofluorescence. By this geographic atrophy lesions, they appear as hypoautofluorescence because there is an RP atrophy. But the main demerit of this autofluorescence is it is easily influenced by nuclear lens opacities, vitreous floaters, pupil dilatation. And also, as a macular pigment, that is lutein pigment, they blocks blue light, so leading to a relatively decreased signal intensity at fovea. Near infrared reflectance, it uses near infrared wavelength 780 or 820 nanometers, which are longer than autofluorescence wavelength. You minimally absorbed by media opacities, and fovea ka determination, it becomes more easily, determination can be done more easily with this imaging modality. Optical coherence tomography, they are identified by the loss of RP and photoreceptors and increased hypertransmission leading to the visibility of choroidal vessels. OCTA, that in this, changes in the choriocapillaries appears to be present during all the stages of this disease, and choriocapillaries scan the areas of signal flow voids, which appears as dark region among the granular bright areas representing choriocapillaries flow. There are other modalities also like near infrared autofluorescence. In this, atrophic areas appear hypoautofluorescence from the lack of melanin. And there is a multicolor confocal scanning laser ophthalmoscopy, which uses different wavelengths like blue, green, red, and red/infrared. The blue wavelength is usually used to estimate the vitreous as well as inner retinal layers. Green wavelength is used to estimate the pathologies involved in deeper retinal layers, and red wavelength for the estimation of outer retinal layers as well as choroid. Now, this is the same imaging modalities, different. The most important, the factors which are responsible for progression through which we can estimate that there will be a progression in geographic atrophy. Usually, GA progression rates are 0.53 to 2.6 millimeters square per year. So the lesion size, if the lesion is very big at the baseline only, there's a higher chances of progression. Usually, multifocal lesions size like medium size of geographic atrophy, they'll progress more faster. Multifocal lesions will progress more faster as compared to unifocal lesions. Extrafoveal involvement of the lesion, they progress more faster as compared to foveal involvement. And the area of the involvement, if it is outlined, if at the baseline only the outline is very big as compared to this, then there's a higher rates of progression. The most important is fundus autofluorescence patterns. Hypoautofluorescence patches are sometimes surrounded by varying degrees of hyperautofluorescence, especially at the junctions of atrophy. For this, there was a FAM study which investigated correlationship between hyperautofluorescent patterns and GA progression rates. It was a prospective, longitudinal, and multi-center study. In this, they found out that is there any increased FAF in the junctional zone of atrophy? If no, then pattern was known as none. If yes, if only increased autofluorescence adjacent directly to the margin of GA. Single or individual spots, it is focal pattern. Almost continuous ring shaped, it is a banded pattern. Or laminar or homogeneous, it's a patchy pattern. But autofluorescence at the margin as well as elsewhere, that is diffuse, it is divided into 5 parts. It can be reticular pattern, branching, fine granular with peripheral punctate deposits, or trickling. It was found that patchy dystrophy as well as diffuse type of atrophy, they are at more high risk for the progression of GA, and especially in diffuse trickling pattern is at the highest risk for progression. Now, OCT features early OCT features which can show the progression of early atrophy to the geographic atrophy. Then it can be divided into inner and outer retinal layer abnormalities, in which we actually see there is an inner nuclear layer as well as outer plexiform layer subsidence, that is thinning, and they tries to bend towards RP. Then there's a hyporeflective wedges formation, hyporeflective wedge, as well as ELM descent towards the Brooks membrane, as well as external limiting membrane and ellipsoid zone ka disintegrity. If these are seen in cases of early atrophy, there are chances that it will soon progress to geographic atrophy. Intraretinal hyperreflective foci, as well as drucenoid pigment epithelial, they appears usually as a smooth dome-shaped elevation of RP with homogeneous internal reflectivity. Cuticular drucens, they appears as on fluorescent angiography as starry sky appearance. Calcified drucens, refractile drucens. All these cuticular and calcified drucens on autofluorescence, they usually appears with hypoautofluorescent center surrounded by a hyperautofluorescent zone. So all the drusen's which are of this pattern, that hypo autofluorescence inside and border surrounded by hyper, they are at more risk of progression to geographic atrophy. Now this is drusenoid PED. They have a homogeneous internal reflectivity. And on fluorescent angiography, cuticular drusens appears as a starry sky pattern. Then there are subretinal drusenoid deposits also, which are known as reticular pseudodrusen. It's an accumulation between RP and photoreceptors. Now this accumulation, it can be divided into 3 stages, in which the first stage is, it is below the ellipsoid zone. Second stage, when it goes striking the ellipsoid zone, and when it goes beyond the ellipsoid zone, it defined as a third stage. Third stage is at more risk of progression to geographic atrophy. Acquired vitelliform lesions, they can be found in combined with cuticular drusens, and on fundus, they appears as a yellowish elevation, and on OCT, they appears as a dome-shaped deformity with hyperreflective mount, and on fundus autofluorescence, they appears as hyperautofluorescent. OCT features which predict the progression of geographic atrophy is ellipsoid zone ka disruption, outer retinal tubulations, decreased subfoveal choroidal thickness, and vitreoretinal traction. Now, if the fellow eye is also involved, the median time interval from becoming unilateral to bilateral AMD is 7 years. It progresses at a greater rates faster when the fellow eye has geographic atrophy. And 7% of the eyes with geographic atrophy will develop choroidal neovascularization in 2 years. This is a diagram of representation of outer retinal tubulation. Now, this is just a lesion characteristics which are identified as prognostic factors for geographical atrophy progression or late or location. So, affected highest evidence is large baseline lesion size, multifocal lesions, banded or diffuse pattern of FAF, non-foveal location. And fellow eye, high evidences if there is a bilateral GA and higher progression rate in fellow eye. Moderate evidences, prior higher progression rate, greater extent of abnormal hyper autofluorescence, and structural abnormalities noted at junctional zone. Geographic atrophy progression and visual function. It can be determined by some tests like microperimetry, which measures the threshold light sensitivity at macula. Decrease in retinal sensitivity, actually, it's noted with GA progression rates, and decrease is associated with increase in autofluorescence in junctional zone. Low luminance visual acuity. It measures visual function in low luminance, and deficits are associated with higher GA lesion progression rates. Low luminance deficient can be determined by difference between BCVA and low luminance visual acuity. Reading speed, it reflects whether central field is preserved or not, and low maximum reading speed at baseline, it indicates poor prognosis. Now, treatment, they all are actually undergoing trials only. Various complement factor in various medications, drugs have been tried to inhibit the various stages of complement system. Like for complement factor 1, complement factor D, complement factor 3, 5, membrane activating complex, and complement regulation. Complement factor D inhibiting is lampalizumab, and there was a phase 2 trial, Mahalo trial, and now it's undergoing phase 3. And now this is also a diagrammatic representation of this. That complement factor D targeted by lampalizumab, properdin, which is involved in the progression of geographic atrophy. So it can be inhibited by the drug CLG561. C3 complement factor inhibiting are APL2, and C5 inhibitors are eculizumab, LGF316, and Zimura. Now there are other drugs apart from complement factors inhibiting drugs. There are other drugs also like doxycycline, which is used as an anti-inflammatory drug. Vitamin A dimer, modified vitamin A dimers, which can be used as a replacement of vitamin A, visual cycle modulator. Then brimonidine used as a neuroprotective agent. Then ciliary neurotrophic implant, intraocular implant, anti-501. Then these pathway inhibitors like ONL1204. These are all undergoing trials. Other potentials are lipid modulators, choroidal perfusion enhancers, MC11001, stem cell therapy, induced pluripotent stem cell therapies under trial, and artificial intelligence. The most important is visual rehabilitation. Usually these patients will have a difficulty in the vision. So the goal is to use the remaining vision to the fullest potential for the patient to function independently. Now there are various low visual aids available like distance magnifiers, near magnifiers, image relocation with the prism, so that the image from fovea to parafoveal, the image is shifted, and non-optical devices. These are various pictures like this is uniocular telescopes, binocular telescopes, stand magnifiers, pocket magnifiers, Fresnel magnifiers, then pocket CCTV, then signature writers, then CCTV talking clocks. Okay. Now this was the latest, in 2015 it started actually. There was an international group which recommended to define atrophic stages of AMD to be named according to anatomical layers affected on OCT. This was termed a classification of atrophy meeting. They gave actually 4 terms like complete RP and outer retinal atrophy, incomplete RP and outer retinal atrophy, complete outer retinal atrophy, and incomplete outer retinal atrophy. Geographical atrophy, the term was considered as a subset of complete RP and outer retinal atrophy. And there was a term which was given as nascent geographic atrophy. It was considered as a subset of incomplete RP and outer retinal atrophy. So the criteria for diagnosis of complete retinal pigment epithelium and outer retinal atrophy was on OCT, there is a zone of hypertransmission of more than 250 micrometers, zone of attenuation or disruption of RP band more than 250 micrometers, evidence of overlying photoreceptor degeneration, whose features include outer nuclear layer thinning, external limiting membrane loss, and ellipsoid zone or interdigitation zone loss. On fundus autofluorescence, sharply demarcated borders, hypoautofluorescence, and diameter more than 250 micrometers. On near infrared reflectance, hyper-reflective, sharply demarcated borders. And on multicolor images, sharply demarcated borders, hypopigmentation with increased visibility of choroidal vessel. This was the criteria for diagnosis of complete RP and outer retinal atrophy. This is a OCT image of complete RP atrophy and outer retinal atrophy, in which we can see that there is an RP atrophy, increased visibility of the choroidal vessels, and photoreceptor loss. This is as incomplete atrophy, in which it does not fulfill the criteria of complete atrophy.
Yeah, very well presented. I congratulate you. You have covered almost geographic atrophy entirely.
Thank you.
So maybe we can ask any PGs are there? You have understood what is geographic atrophy? Any doubts? What is the differential diagnosis if you see a patient with atrophy at the macula? What is the differential diagnosis that you will entertain?
Chloroquine toxicity.
That will be your first differential diagnosis. Sorry?
Target dystrophy, vitelliform dystrophy.
So, in other sense, what are the features that will confirm geographic atrophy in a patient for you? When will you say that this patient has geographic atrophy and not something else? Okay, anybody else can answer, no problem. She already explained in the presentation. I am just trying to summarize it and recollect the main features.
Yeah, geographic atrophy usually seen in ARMD. If it is patient has a agitated macular degeneration, then later the geographic atrophy can form.
No. I want to know if a patient has come to you in OPD, what are the features which will tell you that this patient has geographic atrophy?
So the complaint will be diminution of vision and lower reading speed, and reading speed will be less in the low illumination. That will be the complaint. And on clinical examination,
First of all, what will be the age of this patient?
Yeah, usually more than 50 years. Means
Yeah, so elderly
Yeah.
patient.
Elderly
First of all,
patient.
patient is an elderly patient. You won't
Yeah.
be calling a geographic atrophy if a young patient comes to you.
No. Yeah.
Elderly patient. Then, yeah, no. First we'll go, methodically. First is the age group of patient. Then patient is complaining of whatever visual symptoms. So what will be the duration of the visual symptoms? Isn't that important? Will the patient come to you with sudden diminution of vision?
No, it will be the means gradual progressive diminution of vision usually
Yeah.
in geographical atrophy.
Gradual diminution of vision for a very long time.
Yeah.
So it's not something which has happened 3 days back, 4 days back. And a patient is not going to tell you that. So an elderly patient who has long-standing diminution of vision who comes to you, okay. And then next, what are the other features that you will look for?
Drusen's
Complete
or in the same eye or the fellow eye of the patient, or if there is CNVM or any wet ARMD in the other eye also, and there is something like this in this eye, then we can think of geographic atrophy. So basically, any ARMD, wet or dry features, and geographic atrophy plus the age of the patient.
So what is the prevalence of CNVM in patient with geographic atrophy, Garima?
7% of the patients with geographic atrophy will develop CNVM by 2 years.
In the same eye or fellow eye?
Fellow. I'm
Okay.
not
How
sure.
common have you seen any patient with geographic atrophy in one eye and CNVM in the other eye?
Rare only.
Okay. So CNVM is not that common. And what is the difference between geographic atrophy and the atrophy that you see following a CNVM?
ARMD we can see the geographic atrophy, but in CNVM that it is skipped from atrophy later.
Yeah. What are the features? How will you differentiate?
In geographic atrophy, typical area of involvement is temporal to the fovea, but in case of CNVM following atrophy, it will be in the fovea mostly.
It appears more like scarring as compared to atrophy. It appears more like scarring.
Okay, very good. So this geographic atrophy will be more of degeneration, atrophy, so loss of tissue. Whereas this scarring of the, what we say after CNVM will have more of fibrosis, more of scarring. So you'll see thickening of the tissue. So that area of CNVM will be thickened because of fibrosis. Whereas geographic atrophy will be thinning and loss of tissue. So you will see the choroidal vessels and RP loss, which can be seen very well. So it's rare to have both together. You will have probably drusen, but geographic atrophy may not be there if the patient has CNVM.